questions at your convenience. And at this point, I'm going to go ahead and turn it over to Mary. I think it's you who's going to be setting things up, right?
Hi, this is Mary DeCoster. I just wanted to welcome everybody to today's webinar. We've been wanting to do this for a long time. I am the TOPS Senior Specialist for Behavior Change Programs, and I also co-facilitate the Food Security and Nutrition Network SBC Task Force. People often ask me what's the relationship between the FSN network and TOPS, and Patrick explained it to me in a one-liner, which I like, and I'm adopting. Basically, he said TOPS resources and convenes the Food Security and Nutrition Network. This material today, we have a TOPS endorsed, a list of TOPS endorsed tools in our resource library, and we'll be telling you more about that later. A partnership defined quality facilitation guide is on our list of endorsed tools. So that means that it's something that we consider basically useful innovation or best practice that we would encourage people to become aware of and to use. And we've been wanting to people have been asking for a webinar along these lines for quite a while, and I'm really pleased that Kara and Beth were able to pull this together. I know that we'll need Patrick to put the slides up for the next part. Has everyone had a chance to fill out the poll? So I'd like to turn this over to Kara Greenblatt with Zynga Consulting, and Kara is going to take it away, I think. Let me ask Patrick if he's able to put up the slides. Sorry, guys. Okay. Okay. All right, go ahead, Kara. I think Patrick's going to.
Sure, I'm here.
Yes, I can.
Well, it's interesting to see the results so far. Okay. Can you hear me okay, Mary? Okay, terrific. And here comes the presentation, the PowerPoint, so I'll hold on for a minute. I'll just reflect on those poll results a little bit. I noticed that the vast majority of people here today have not used the PDQ, so this will be new to a lot of people, which is great. So I'm really excited to be here today, and I want to thank TOPS, Mary and Patrick in particular, for putting resources into conducting this webinar on PDQ. It's fairly new to me, but in my opinion, it's an exceptional tool. It has a great track record for improving access to health services and also improving quality of services. But as we'll talk more about in this webinar, it also, as importantly, brings the voice of the community into the mix. And actually, voice of the community might be a misnomer. I'd say it's more like voice and shared responsibility to improving service delivery. So with that, I'll get started, and I'll start out by introducing Beth, and I just want to make sure I can advance the slide. Okay, there it is, the bottom left. Okay, so there's me, and my co-presenter is Beth Outerson. And Beth is, we're really fortunate to have her here, actually. She has extensive experience with PDQ and is now with Medical Teams International out on the west coast of the U.S. And while she was with Save the Children for many years, she used the PDQ in Bolivia, Guatemala, Malawi, Bangladesh, Nepal, Vietnam, Pakistan, and Armenia. And now at MTI, she'll be soon using it in Uganda and Liberia. So I'll also just add that in programmatic terms, Beth has applied the PDQ in the areas of maternal health, reproductive health and family planning, and adolescent reproductive health. And she's currently planning to use it with MTI for MCH in refugee resettlements in Uganda and in Ebola-affected communities in Liberia. So thank you very much for being here with us, Beth. I also want to take a minute to introduce our resource people. And I'm going into a little bit of detail with Beth's background and with our resource people's background because I am expecting that at the end of this webinar, all of you will be so excited about using the PDQ that you will want to get out there and apply it in your projects. And these are people that you can turn to for questions. So it's helpful to know where they've applied it and in what contexts. So we're very fortunate to have two of the original developers of PDQ with us today, and that is Ronnie Levitch and Marcy Rubard. We also have Dr. Shahana Nazneen, and Dr. Shahana was one of the pioneers in the implementation of PDQ, specifically for adolescent reproductive health. I'll start with Dr. Shahana, and she has applied PDQ in Bangladesh, where she's located, in the areas of MCH, including family planning and adolescent reproductive health. She has been a lead facilitator on PDQs and also trained staff to facilitate PDQ exercises. I'll move to Marcy. Marcy has implemented PDQ in Nepal, Nigeria, Rwanda, and Myanmar. She has applied PDQ in health services generally, as well as sexual and reproductive health, and she's led a university-level youth-focused PDQ in the context of HIV prevention in Myanmar, and that was done in collaboration with Ronnie, our next resource person. And we have Ronnie Levitch at the bottom there. Ronnie is now with EGPATH, but formerly with Save the Children, and while there, she worked on PDQ or applied PDQ in Nepal, in the areas of reproductive health and MCH, maternal and child health, in Uganda on family planning and reproductive health, Ethiopia on HIV services, and the Republic of Georgia also in HIV. So you'll see that they've all been kind enough to share their emails in case you want to get in touch with them later on. I'm now going to take you through the agenda for today. And we'll start out with what is PDQ and why does it matter. And then we'll move to how PDQ works. And I'm going to take you through the 4 phases or 4 kind of stages of PDQ. Next, we will do something called exploring quality and bridging the gap. And that is putting PDQ into practice. So we have kind of a simulation exercise that Beth is going to take us through. And then we will hear from Beth on a couple of case studies from Pakistan and Armenia, some exciting results from those 2 countries where Beth had the opportunity to use the PDQ. And then we'll talk about where you can find the resources, and we have some final thoughts on PDQ there as well. And we should have some time at the end for Q&A. So I'm going to start out by asking the question, what is PDQ? So PDQ is a type of QI or quality improvement methodology, and as such it was designed to improve quality and to improve accessibility of services. PDQ was developed by Save the Children back in 2002, so it's been around for quite a while, and since then it's been implemented in just about 20 countries. We sort of lost count, but we think it's 20. The earlier rendition or earlier version of PDQ was called Community Defined Quality, so CDQ, but it was later changed to PDQ to emphasize the role of the partnership between the provider and the community and the collaboration that's required for success. So PDQ links 2 worlds. It's the world of QA and QI, so quality assurance and quality improvement, with the world of community mobilization. And it brings those 2 together into one tool. And finally, PDQ was originally designed for health services, but later adapted for youth-friendly health services. And I'll make a point here that it is easily adaptable for a variety of geographical contexts, but also for other sectors. You'll see as we go through it, there's nothing health specific about the method itself. So why does PDQ matter? And here I'm going to actually, before I go through kind of our opinions on why it matters, I'd like to hear from our resource people.
For me, I really liked
let me
your
start with
comment
Marcy.
that
If
it
you
links
could
the two
unmute
worlds,
yourself and
the
just
world
in a
of
couple of
quality
sentences
assurance
maybe tell us
and the world
from your
of
vast
community
experience with
mobilization.
PDQ why it matters. Why
Because
should we be using
for me,
PDQ?
people in the healthcare system, and I actually, even here in the last few days, I've been in the healthcare system with my aging dad. When you're not well, you have no power and you feel like you have no control. And what PDQ offers is it offers a way for people in the community and people who are users of these services to feel like they don't just have to get what they're given, that they have some rights and that they have a way to assure that what they're given meets their needs. Thank you.
Hi, I'm there. So, like Marcy, I think it's the bringing the two worlds together. Can you hear me?
Great, thanks very much, Marcy. Excellent point.
Can you hear me?
Ronnie, are you there? Do you want to give us your perspective?
So as Marcy was saying, bringing the two worlds together is really what makes this all work. And
hey, Ronnie.
It's interesting. Before, when I was at Save the Children, and most of the work that we were focusing on there was largely around community health, and of course with strong linkages to services. It was all about getting the community voice in there. And it's interesting to me now that I'm in an organization that focuses quite a bit on health services and systems, looking at it from the other side. It's that mutual accountability and getting away from some of the more, I don't want to say blaming approaches, because I don't think they set out to be blaming, but, there ends up being quite a bit of blame in some of the quality work out there, because health workers are basically blamed as providing poor quality or disrespectful services. But the reality is that they're facing a lot of hardship in their jobs. A lot of them are in under-resourced settings. Some of them haven't been paid in a long time, and they're not getting the support they need from the system. The Partnership Defined Quality approach provides an opportunity for health workers to feel better supported by different parts of the system, not only the health system, but also some of the other leadership that's out there. But most importantly, they feel better supported by the communities and able to involve them in problem solving. So, in order to get better care for clients, health workers themselves need to be better supported. So, looking at it now where I sit, I think that that's been incredibly useful.
I don't think she's set up.
Thanks very much,
she
Ronnie.
hasn't been responsive, so maybe she's
having
some
points,
technical.
and some of which will be covering later in the webinar. And Dr. Shahana, do we have you mic'd up? Are you able to share with us verbally?
Hi, can you hear me?
Okay.
Yeah.
Okay.
No
problem.
interesting because my work.
Beth, we have you on board. Do you want to chime in and give us a couple of comments
so
from
I
your
think
perspective?
about, the increasing the awareness among community members who maybe never knew that they had rights. So what I like about PDQ is it really brings people from awareness to really kind of demanding services. So that kind of empowerment is really kind of cool. And to be able to see that and have a methodology that promotes that is really awesome. So that's what I like. One of the things I like about PDQ.
Great. Thanks a lot, Beth. Thanks for chiming in there. So a lot of what I have up here has been covered by our speakers. Why does PDQ matter? It recognizes that quality may be defined in different ways depending on your perspective, and we will talk a lot about that today. It reduces barriers to care in by incorporating the client or the community's perspective on those barriers. It also builds social capital of the client or the community and ownership in healthcare, and Beth alluded to this. So here, when I say social capital, it's defined as value derived from the connections between individuals and between networks. And second to last, PDQ brings non-users of the service into the process. And this obviously provides a very valuable and much needed perspective, as Marcy alluded to. And finally, recognition that the providers and clients can work together as allies to address problems. And this speaks to Ronnie's point of the tool helping to overcome the tendency to blame one another. So when should we use PDQ? Well, the best circumstances in which to use PDQ is when action is needed. So this is a tool that's not just about information sharing. It's meant to find and implement solutions to problems. It's also good to use when stakeholders, both providers and the community, want change. And critically, there has to be a willingness to listen to one another. And finally, PDQ can only really be used when there are two clear partners and where one is obligated to be a provider of a service and the client or the recipient of those services has the right to receive the services, but for some reason isn't receiving them at the time. So a few points on how PDQ takes QI beyond quality improvement. The first is about social accountability. So as part of the PDQ process, marginalized members address duty bearers directly. And this is a really empowering and inclusive process that focuses on including those who have never actually used the health services or have maybe used them on a limited basis. As a side, there's a fairly new document out called The Role of Social Accountability in Improving Health Outcomes, and it's an interesting read, but it also cites PDQ along with two other methods that use social accountability. And the other methods are CARE's Community Scorecard Model and World Vision's Citizen Voice of Action Model. And you can easily Google either of those to get more information. The community takes ownership to improve health using existing resources, making solutions more sustainable than they would be if they were not involved. And it's also, it takes QI beyond quality improvement in the sense that client satisfaction and provider performance increase along with overall health status. And I'll just note here that we often hear marginalized community members exclaim that no one has ever taken the time to listen to and to value their point of view. So the PDQ process is actually very personally empowering for them. And finally, PDQ creates a mechanism or a process for rapid mobilization around health priorities. And those are priorities that are agreed commonly by both sides. So just a photo here from Zambia of patients waiting in line at an eye clinic. And in PDQ, the community is not just asked for their views and opinions. They are asked to participate and share responsibility and efforts for quality improvement. And that's kind of a key, in my opinion, a unique feature of PDQ. So I listed a lot of these countries earlier when I introduced the resource people, but I think it's interesting to see how many countries PDQ has been applied in. So really quickly, it's been used to increase use of facility-based MCHN in Nigeria, Nepal, Uganda, Haiti, Burkina Faso, and many others actually. Also to increase access to reproductive health and or HIV services in Guatemala, El Salvador, Nicaragua, and others. Also to increase use of adolescent-friendly services, and this was using the PDQ for Youth manual, which I'll throw up in a slide in just a minute. And that was in Bolivia, Bangladesh, Nepal, Malawi, Philippines, and several others. And finally, I alluded to these two earlier. These are Beth with MTI is going to be applying the PDQ in post-Ebola transitioning to development in Liberia, and then again in refugee resettlements in Uganda. So how PDQ works. These next slides, I'm going to be taking you through the stages of PDQ, and there is some preparation involved to plan and design the PDQ process. And then there are 4 phases. So the phases are building support, exploring quality, bridging the gap, and working in partnership. And we'll go through each one in some detail. And before I do that, I just want to point to the key resources for those of you that would like to go out and apply the PDQ method. These are fabulous guides. They take you through step by step, and they are packed with all kinds of participatory exercises to get the best outcomes for each of the 4 phases. So in the back left, you've got the original manual that was written by Save the Children in 2003. 2003, that's right. And then on the right, we've got the PDQ for Youth. And then in the front left, the more recent facilitation guide. And all of these were published by Save the Children. So before the 4 phases begin, there's a significant amount of preparation for PDQ. So the assumption is that the CBO or the NGO that's applying PDQ is already in the community. So some of these may be done as part of the design and implementation of the actual project. The steps of preparation include identifying people with the necessary skills for implementing PDQ, including a neutral facilitator, and then people with the appropriate language, skills in community mobilization, etc. Secondly, defining and agreeing to the goals and documenting them, of course. Thirdly, identifying the level of service. So will PDQ be applied, for example, at a health post, a referral hospital, a district hospital? And then identifying the community, which members in the community it will be used with. Fourth, as part of the prep work, you'll want to conduct some kind of community mapping, and that will include service providers and community structures. So, for example, who in the community has power and influence. And then finally, planning the facilitation and representation of the PDQ. And ideally, you'd have a balance of non-users and users. You'd have a balance of providers and clients, men and women, and be sure to include people outside the power structure as well. So for phase 1, building support, there we go. Building support, people will only take action on issues that they understand and perceive to be a priority. So this step is really about getting consensus among decision makers and different affected groups that there is indeed a problem and that solving that problem is a priority, and then getting their buy-in and their support for implementing PDQ. So the buy-in is essential because later in phase 4, the quality improvement team may need these same decision makers to use their authority and possibly their finances to come up with, to help them accomplish the various action items that are identified during the process. So the steps here are determine who to contact, the potential partners, decide how to present PDQ to the stakeholders, present mapping results, which would have been done in the preparation stage, and also how to present the PDQ process to potential partners. And finally, to discuss why quality matters and what is the cost of poor access or poor quality for these communities. And so these first discussions about quality happen here. So I have a few rules of thumb throughout the presentation, and the first one is don't forget the non-users, and this is critical. And when I say non-users, of course, I mean those who have never or don't currently use the services. It's the equivalent of non-doers for those of you in the behavior change world. And it may seem obvious to not forget about the non-users, but it doesn't always happen automatically. So for example, in Nigeria, PDQ was used to improve school attendance and quality of education. However, participants from the community side were mostly drawn from PTAs, so those are parents of kids already in the system. Adjustments then had to be made to make sure that the non-users of the education system, so meaning the families whose children were not in school, were then brought into the process. And of course, these families had a unique and valuable perspective. So sorry about that, I'm behind by one slide. And there's the slide for what I just reviewed, the rule of thumb on non-users. So the second phase of the PDQ is called exploring quality. And quality services are not one size fits all. Perceptions of and expectations for quality come from each person's own understanding and experiences. And the purpose of this phase is really to understand both the community's perspective on quality and the provider's perspective on quality. And this is done through interviews, both individual and group, with the client side and also with providers. And once it's done, the comments and the thinking around quality and the complaints from each side's perspective are analyzed and categorized in preparation for the Bridging the Gap workshop, which is the next phase. And you'll get a better sense of this in just a couple minutes. We're going to take you through an exercise. So the market exercise, this is one of my favorite slides. These are tomatoes in a market in Blantyre, Malawi. And this exercise is often done with the community just before the exploring quality phase. Often participants have a hard time grasping the concept of quality when we start discussing health services. So they might feel that they don't really have much choice about the quality of the health services they receive, but they do make choices for quality in other realms of their lives. So the market exercise helps to launch a discussion about quality by beginning with a topic that they can relate to more readily. That is the quality of goods they purchase in the market. And then we transition to a conversation on quality of health care later in the exercise. So just as an example, the facilitator might ask the participants, what is it, the community members or the clients, what is it about the tomatoes that makes you want to buy them? How do you choose what tomatoes you buy? And the facilitator might probe for specific information and typically gets responses like the color, we want them to be really red, the smell, they need to smell and feel fresh. So when the community group then feels satisfied with the list they've constructed of qualities of the tomatoes, the facilitator will then probe for what they might expect from the seller or the vendor. And the community members might respond they would like to buy their tomatoes from someone who's very honest, from someone who's friendly, from someone who has a clean market stand. And we get to, we sort of build up a concept of what quality is by using the market example. So linking quality to purchasing decisions helps community members see their role in the healthcare services, in healthcare services as consumers and not just as patients. And by exploring areas where the concept of quality is more familiar, participants are better prepared to describe elements of quality that they value in health services. So when PDQ was first conducted in Nepal, provider performance skyrocketed. Exam rooms were cleaner, providers became more efficient with their time, and there were noticeable differences in many aspects of service. And it was like the providers were suddenly, really paying attention to their work and taking more pride in it. And part of the reason for this is that it was the first time they'd actually had this forum for communication and were able to hear the things that their clients really wanted and needed to have as part of their service. So I'll also just make the point that you can adapt this to, the context of the culture you're working in. So in Myanmar, for example, a tea shop was used instead of tomatoes in the market. And in West Africa, or I guess anywhere in Africa, really, you could use a hair salon. And there's lots of other exercises like the market exercise in the manual. So a rule of thumb here is just that in discussing quality concerns, help participants to avoid assigning blame. And this kind of comes back to what Ronnie mentioned early on in the webinar. So the reason that people do not seek services are more often than not socially determined and subjective as perceived by the client and the provider. So it's really the job of the facilitator to paraphrase comments and to communicate them in an unbiased manner. So for example, if the patient if the staff say patients don't take their medications correctly because they don't listen, it might be better to paraphrase and adjust that to something like patients don't take their medications properly or as directed, or even leave off the end and just patients don't take their medications, and then explore the cause for that later in the PDQ process. So I think I'll pause for just a moment and see if we have any questions thus far. I don't see any listed, but feel free if anyone wants to type some into the chat room. There is time to address them throughout the webinar. If I see some come up, I'll come back to them, but for now I'll keep going. So phase 3 is about bridging the gap, and I like this cartoon with the elephant. Many eyes can look at the same thing and see something different, or in this case, many blind men can touch the same elephant, and I'll come up with a different interpretation of what they're touching. So the purpose of this phase is really to get to an understanding of the varying perspectives of quality and to integrate those perspectives into one shared vision of quality. And it's usually done in a one-day workshop made up of everyone who participated in the focus group discussions and the interviews from the previous phase. And the health facility staff and the community will then present their point of view to one another. And they develop a list of joint issues using a Venn diagram. And we'll, as I said, get to this in a little bit. So bridging the gap is really where PDQ starts to become very transformative, because it's where the community must be listened to by the providers, and then the providers must also be listened to by the community. So the components of this phase are, number 1, team building, number 2, developing a shared vision of quality, number 3, problem identification, and number 4, selecting and starting to form the QI teams, the quality improvement teams. And a rule of thumb for this phase is during the Bridging the Gap workshop, the facilitator must be highly skilled and completely neutral in order to maximize honest participation between the groups. So just emphasizing the necessity for being unbiased. Phase 4, the final phase, is called working in partnership. And problem solving is a skill that the team can develop together. So the purpose of this final phase is to provide QI teams with the tools to implement a continuous QI process and to establish a process for ongoing review, including deciding, for example, when a problem is already solved and when it's time to move on to a new one. And this phase involves reviewing the QI action cycles so that the teams understand the process and their role. And we won't go into those action cycles here. They are in the manual, and that's a whole other area that we don't have time for. But if you go to the original manual, you'll see how that's explained there. It also involves team building and promoting communication between marginalized members of the community and providers. So, for example, in Peru, the health staff actually spent an overnight in the homes of the community members in order to get to know them better. And this, as you can imagine, was fairly unprecedented. So the point here is really becoming a team. And then thirdly, analyzing the problems that were identified in phase 3 using tools like the fishbone analysis or the problem tree. And I've put up the fishbone analysis here just to give you a sense. So the head of the fishbone is the actual problem, and then you've got kind of the bones sticking out, which are the causes of the problem. And I'll get to the end of this slide, and then I see that there is a question. Let's hold on for just one moment. So then the next point here is formulating solutions is done during this phase, so solution strategies and developing an action plan. And then reviewing progress by identifying indicators to gauge whether QI activities are actually working, and also to measure progress along the way. And then finally, this phase involves establishing tools for self-management so that as you go forward, you have a skilled and effective quality improvement team. And I see that there's a question. Let's see, Dr. Salazar. So a major emphasis or starting point would be community mobilization conducted via prelim analysis. And I guess you're asking whether that's the case, to just confirm that. So that's my understanding, but I am going to turn that over to any of our resource people to make a comment on that. Is there anyone who would like to? Marcy, Ronnie, or Shahana to comment on that? Shahana, if you don't have mic capability,
the community mobilization piece is central and maybe the starting point. When
Marcy,
we were developing
there you go,
the
Marcy's
PDQ,
here with us. Go ahead.
The community piece was Save the Children's strength. And at the time, Save the Children was not working very much in health services strengthening. So yes, that was clearly Save the Children's starting point. But it depends a bit on where you're starting. And if you're starting, and Ronnie, you may have something to add with your EGPATH work, but if you're starting with a health services strengthening perspective, then the challenge is the reverse. And how do we bring community participation into what has traditionally been a health provider's domain? So I think that's very much part of that early step of preparation and design and building support, because you need to look at where your current base is and what is currently missing. That said, I would also suggest that even though with Save the Children we were very much focused on the community, often we were still missing the marginalized or unempowered people. Because when you have community meetings and when you listen to who speaks up, that tended to be the people we were working with, unless we purposefully made an effort to say, so where are the people who don't use services? So I think your starting point really depends on where you actually are when you start, and how do you make sure that all the pieces are coming into play as you explore what is the definition of quality and how do you bring different stakeholders together. Thanks.
And I believe Shauna's mic. Sorry, I just wanted to say I think Shahana's mic might be working now, and she wanted to chime in. Shahana, do you want to give it a try?
Can you hear me?
Great, thanks very much, Marcy.
Yeah, we can.
So
I want to talk about the community mobilization. It's not only about one big community mobilization, but what we work that we have very community mobilization in the small groups. Like when we work with the adolescents, we have many adolescent groups like boys, girls. Among the girls, there are married, unmarried groups. There are vulnerable groups based on their professions. So we had many groups, and we also have the groups among the community who are the adults. There are community like some of them are decision makers. Some of them are working for the government, like they used to work as the provider, not only for health, but also for other services. They used to provide some services at the village level. And there are some elite people. So if we think So there are many groups where we have conducted community mobilization process, and after some time it becomes a big process. And I think when we talk about the community mobilization process, it's a continuous process throughout PDQ. It's beyond phase 4, which is actually the continuous process, and if it continues, then we can say that it's working.
Yeah, absolutely. You know, when we started the work and started to think about applying it in other countries, we looked around at existing structures like health management committees. In Malawi, for instance, they had these village health management committees that weren't functioning terribly effectively. They had kind of token participation from the community, and they didn't really have a good like terms of reference for how they were going to operate. And so this process actually gave them some structure and some, you know, like a blueprint that they could follow. But just to build on some of the points that were made earlier, you know, participation is everything, and having the right participation matters. First, it can't just be token participation. As Shahana was saying, you really need to have participation from the diverse target, like subpopulations that you're trying to reach. You need to have sufficient gender balance and participation of women, and the overall ratio of how many people from community versus health workers or people from the systems are there, because it is a lot harder for the community representatives to feel supported and you know, be bold enough to engage. So anyway, so how you compose the group is really important. But I just, to come back to this second question again, you know, there are lots of different structures out there, and using what you have is just great, as long as you can get those committees to reflect on their own composition and whether they have the right balance of participation. Just to give one further example of this, in Uganda, after we had been doing the Partnership to Find Quality Work with Reproductive Health and Family Planning Services for a while, some people in the education sector picked it up and realized that they had these village education management committees that were mobilized but not really functioning, and they ended up using the methodology for a Safe Schools initiative, which had some really nice outcomes from that work as well. So I'm a big fan of using, you know, starting with existing committees, but just make sure you have the right participation.
Hello, can you hear me? Hi, sorry about that. I thought I had clicked on it and I think I double clicked. I was just typing in a response to Mary, who was saying, what is QIT? And so it's QIT stands for Quality Improvement Team. So that is kind of the group that's formed at the end of the Bridging the Gap workshop and follows through phase 4 and beyond. So this is the group that includes some marginalized, some providers, and some community members that are carrying forward the action plan. So when we say QIT, that's what we mean, Quality Improvement Team. And that's the one that can be integrated with other existing community groups. Okay, so this is a really exciting discussion, and I'm really enjoying hearing comments from our resource people and just thinking through all the different ways the PDQ has been used, but possibilities for other uses as well. So now we're going to go through a simulation exercise, kind of taking elements from phase 2, exploring quality, and moving into phase 3, bridging the gap. So we're going to use the example of adolescent reproductive health in rural Bolivia, and the two partners are going to be adolescents age 15 to 19 who are seeking reproductive health services and information, and health providers at the local health center. And the purpose of this exercise is to understand the barriers to utilization from the perspective of the two groups. And then when we come back together, we'll look at some of the commonalities in their perspectives. So now Patrick is going to help us to divide into two virtual groups, and you will have a chance to type in the chat box your response to your question. So here we see two groups. So you will either be in the adolescent group or the service provider group, and you won't be able to hear the people in the other group, so you kind of have your own little soundproof chat room. So if you're in the adolescent group, you'll put yourself in the shoes of an adolescent, and your question will be, what are the things that make it difficult for you to get reproductive health information or services at the health clinic? And if you're in the service provider group, your question will be, what are the obstacles or things that get in the way of providing reproductive health information and services to adolescents at this clinic? So we're going to have 5 minutes in the group, and Patrick's going to help us kind of manage this. And you'll be able to just do a brainstorm list, and you can type it in the chat box, and then Kara and I will be leading the two groups, and we'll be kind of putting the joint responses in another little notes section. Does that make sense? So Patrick, are we ready to divide?
That's great, Beth.
Yeah, let's go into groups. Kara and Beth, I'm going to launch it now, and then the two of you can lead each of your groups. All right, here we go.
Okay. Hello? Hi. How'd it go? Yeah. Yes. I think I ended up just copying and pasting people's comments, so we've got some of their names there. But is everyone back?
Yeah, we're all here.
Okay, excellent. Okay, thank you, Kara. So this was kind of fun. This is an exercise to kind of give you an idea of what happens during the exploring quality phase. It's a data collection phase that's done usually with groups of some of these subgroups of marginalized that we talked about earlier. So it might be with a group of girls and a group of boys separately to find out, what are they thinking? What are those reasons why they're not going to the health center? And then with the providers, it's, the questions are a little bit different. You're asking them questions about, why did you become a health provider? What are the things that, what perspective are you coming from? What's important to you? Some providers are just transferred from another place and don't have a vested interest in the community, or they have real, attitudes or points of view that kind of get in the way of them feeling comfortable providing services for adolescents. So let's see. We've got a whole gamut of answers here. On the adolescent side: embarrassment, afraid, no experience getting health services without their parents, feeling stigmatized, don't know about the services, and so forth. It could be a real need for something like emergency contraceptive or something like that. On the provider side, not getting paid, teenagers have bad attitudes, timing, so the clinic might not be open when youth are in school, or when youth are out of school, not feeling comfortable coming to MCH services, which usually serve mothers and children. I'm not sure what to do, how I get a girl who is 15. So you've got a lot of perspectives here. So we don't have time to kind of link the two, but you can see there are some similarities from the adolescent side to the service provider side. So now we're going to move to the next slide. Let me see here. How do I move to the next slide? Okay, so does everyone see the slide that says responses from Bolivia? So to save a little bit of time, what you have here is the actual list from a PDQ for youth exercise that was done in Bolivia. So you see a lot of similar sorts of things. The adolescent saying, I don't like the provider, he's mean to girls, I'm feeling shy about my feelings. There's let me see, too far away, no private space for me to talk about my feelings to the provider. And on the provider side, some attitude issues, adolescents speak around the issues, they're not clear, they don't respect adults, and so forth. So then what happens after you have these two lists, you kind of group them because you're going to have some that are similar. And then in the next slide, this is an example of what happens when you get to the Bridging the Gap session. What I generally have done is that you're in your workshop, and each of the concerns or complaints from the adolescents or the marginalized group goes on one side of the wall, and then the provider comments go on the other side of the wall, and then you have some blank papers vertically in the middle. So as a group, people can see what are the similarities between what the two partners are saying. And what you often see is that they are really two sides of the same coin. And what I really think is cool is when the participants themselves realize this, that a lot of these issues that we have are actually not unsurmountable because we're all sort of thinking along the same lines. So for example, like the one that says there is no private space on the adolescent side. On the provider side, they're saying there's no space to do counseling with adolescents. So the common concern, the facilitator would ask people, so what is really the common concern here? And it's something like there's no private space for counseling youth. So the facilitator, as Kara said, really needs to be skilled at listening to both sides and kind of articulating what really the common sentiment is. And let me see what else. You have one that says, I'm shy speaking about my feelings to the doctor, and then the provider says, I never learned anything about adolescents in medical school. Adolescents take too much time, they speak around the issues. They're not responsible. So, you know, the common concern might be something like there's poor communication or, you know, attitudes between the two groups. So during the Bridge and the Gap session, you haven't gotten to the solutions yet. You're still kind of synthesizing and, you know, getting precise about what is it that both sides can agree on. You'll also notice by looking at this that there are some comments on the left side that don't have a corresponding comment on the right side. And that's because, you know, it's never going to be perfect, and that's totally fine. There are some issues that aren't priorities for both groups. But sometimes you have an issue that's brought up by one group that really perhaps wasn't mentioned by the other group. So for example, adolescents said there's no running water in the clinic. So the providers hadn't mentioned that. So then the facilitator needs to bring that up and say, is this an important issue? And if it is, then you add it. So at this point in the Bridge and the Gap workshop, after you've gone through maybe like 8 or 10 of these, people are pretty tired, but there's also a real feeling of hope in the group that some of these actually issues can be addressed. And one of the things that was kind of brought up earlier is that this is a rights-based approach. So at the end of the Bridging the Gap workshop, when you're electing the members of the quality improvement team, you need to make sure that you have sufficient representation from the marginalized groups in the room, as well as the providers, as well as other community members. Otherwise, your quality improvement team won't really represent people who don't normally have a voice. So, so that's kind of where we are. I hope that this exercise has helped us to kind of think through this part of the process. If it's okay, I'm going to move on to the next slide and give you some examples about applying PDQ in 2 countries where we've taken PDQ to scale nationally, in Pakistan and Armenia. And almost all of these examples are from Save the Children, which is the organization that developed the PDQ process. Excuse me. Looks like Joseph had to leave, so sorry about that. I believe that this recording will be available for all of us afterwards. So I'm going to continue on. Trying to move forward the slide here. Okay, great. So in Pakistan, the 5-year USAID-funded Paiman project addressed maternal and child health issues. Communities united with health center staff to make some improvements, mostly to the facilities themselves. So in these pictures, you see the proud members of the quality improvement team showing tangible changes as a result of the PDQ process. Things like the water cooler and the dustbins or trash cans, and the floors that are consistently cleaned. A garage was added, and an ambulance has been procured through the Citizen Community Board of the local government. Clean drinking water was made available at 2 health facilities by providing extra pipelines and digging wells. The staff shortage problem was solved by the quality improvement teams by influencing key administrators at the district and provincial levels. And the communities have been mobilized to collect emergency transport funds with the help of local leaders. And one of the quality improvement teams in the Northwest Frontier Province provided curtains in the health center for women in the waiting room so that they could ensure their privacy according to the local Purta tradition. So all of these improvements were solutions that were developed by the community that addressed the problems that were identified in the Bridging the Gap session, and then they later became part of the action plan of the quality improvement team. So I'm going to move on to the next slide. So here we have some results from Pakistan. And as you can see, you've got the orange and the blue. And so the blue is the PDQ communities where we did PDQ, and the orange are the non-PDQ. So because of the community process and perhaps the fact that their behavior was being monitored more closely, the health provider behavior is much improved in the PDQ communities. We measured improved behavior by asking patients in an exit interview whether the provider asked about their welfare, gave more complete instructions for medicines, and if the provider was more open to responding to their questions than previously. So the exit interviews showed increases in client satisfaction as well. So there's quite a difference there. In Armenia, we had Project Nova, and Project Nova was a 5-year USAID-funded project that focused on increasing demand, quality, and utilization of reproductive health and MCH services, and also increasing community awareness about reproductive health and maternal and child health. The project was based on building partnership among healthcare providers, community leaders, and local authorities, and involving and empowering communities in quality improvement. And you can see the objectives on the slide. The project focused on rural primary health posts. And I just want to take a minute to share with you pretty tangibly the before and after. So this is the before picture, and you see there's a cow in front of the health center. It was pretty much abandoned. As a former Soviet republic, Armenia's health posts before were run by the state for many years. And then after PDQ, the community took ownership of the health center and really contributed a lot of their own time and skills and TLC to refurbish the building. And, you know, there was no electricity, the roof had fallen in, and the nurse wasn't even coming to the health center. She was seeing patients at her house. So moving on to the next slide. So the key interventions in Project Nova were, after the 4 phases of PDQ were followed, the key inputs were community education to raise awareness, training of health action groups who provided outreach in the community, and the outputs included an establishment of health libraries, community mobilization that reached 30,000 people with MCH messages, staff capacity building, and health center renovation using mostly community resources. So, you know, this is really important to get the community contribution rather than have all the funds come from the outside, and that's what really makes programs with PDQ more sustainable than other programs. And so this is the after picture. It's really a stark difference. This is the same facility after PDQ, and as you can see, it's just very clean. There were many repairs to the health facility, a new roof, electricity, installation of chairs, and exam beds. The nurse who had been providing services in her home once again started providing services at the health facility. And her supervisor at the district level, who never used to visit before, had started to make monthly evaluation visits. You can see there's an information corner with chairs and pamphlets, and, you know, it's just incredible. I went to this health center and I could just see and feel, the increased ownership of the health facility after all these years of state operation. There was a real feeling of pride and happiness because they had really taken over taken charge of the health facility themselves. So here's some results. There were significant increases between baseline and endline in the utilization of the health post for antenatal care and in the community's perception of increased quality at the facility. And the percentages are here. It's pretty incredible when you look at baseline versus midterm on these scores. So PDQ has been used in a variety of contexts, and there have been many achievements in terms of community improvements led by the quality improvement teams. Once there are some easy wins, the momentum of enthusiasm keeps members wanting to work together for the benefit of their community. So in Afghanistan, for example, one of the things that they realized is that women were not going to the health center because they saw men watching them when they would go into the health center to give birth. So their solution was adding a door to the back of the health center so that the men would not see them and hear them, cry out when they were delivering. So that was a pretty local solution that was very effective. In Nepal, they increased the use of the health center by the Dalit caste, the most marginalized group. They also had better disposal of trash from the health center and a cleaner yard around the health center. In Bolivia, they had increased use of health services by adolescents and youth zones, which were designated spaces in health centers, and also youth-friendly pharmacies. In Bangladesh, the health provider now visits the school to deal with the issue around the timing, and youth hours were established at the health centers 1 day per week. And adolescents also helped improve the doorway to the health center. One of the things that Save the Children did was develop a monitoring and evaluation toolkit that helped to kind of measure some of these changes. And there's a whole bunch of checklists and other tools for measuring the effect of PDQ as it improves quality of service provision. So I'm going to move on to the next slide. So what are the challenges? It's not, a perfect methodology, but it really does achieve quite a bit. It's an intensive, time-consuming process. I would say it takes about 3 months on average to get through the 4 phases in a community. It's not the same in every community, so there are some, questions about how scalable it can actually be. But as we've seen in Pakistan and Armenia, it was scalable in those contexts. One of our staff in the Pakistan experience was quoted as saying that to involve the least advantaged people in the planning team, an ideological shift was required on the part of the program implementers. And I've noticed this to be the case in other countries as well. Other challenges are identifying the right facilitators, maintaining political will and process, frequent transfers of health staff, and gaining true representation and participation at all levels. So now I'm going to pass the microphone over to Kara for some final thoughts on PDQ.
Great, thank you so much, Beth. And we only have about less than 10 minutes left in the webinar, so I'll take you through this at a good pace, and maybe we'll have a couple minutes left for questions. So final thoughts, what do we know about PDQ? So a few things that we know from our experience with PDQ thus far. The first is that PDQ communities have shown improved provider performance and increased client satisfaction. And we have evidence of this, and Beth showed you some of that evidence. Underlying these most obvious outcomes, we also know that because problems are solved together, again by providers and communities, the result is better communication and better collaboration. And the collaboration results in self-reported empowerment and a sense of pride and ownership from the marginalized community groups. And in this sense, PDQ plays a role in breaking down social barriers. There's also some evidence of sustainability. Although often if evaluations are done, they look at overall quality and not at the mechanisms like PDQ that led to the increase in quality. So, for example, in Armenia, Save the Children went back 3 years after the project had ended, and the QI teams were actually still operating, and they were solving new problems in their communities. One quality improvement team had completed their action plan and had moved on to working on constructing a daycare center for the community. So we do have some evidence of sustainability. What is still needed? Well, while it's very clear that PDQ promotes social accountability and that it helps overcome social barriers between the two partners, PDQ is often used together with other methods, so it's actually hard to separate out its unique contribution to improved quality and improved access for non-users. Although we do know anecdotally that there is a transformation that happens in the community when people are empowered, but it is difficult to pinpoint what exactly should be measured in order to get at that transformation. So I guess here what is still needed is more rigorous evaluation of PDQ alone, on its own, and as a complement to other methods so that we can demonstrate its effectiveness. And finally, I just want to make sure you all know about all of the resources available that relate to PDQ. There's the manual that I mentioned earlier. There's the Facilitator's Guide from 2004. There's a document called Maximizing the Effectiveness of PDQ that was produced a little bit later. There's the youth manual that Beth participated in writing. And then there's the PDQ for M&E toolkit, which has a youth annex. Beth talked a little bit about that. And there's also PDQ for improving HIV services. And then there are 11 really well-written PDQ monographs from a wide variety of 11 different countries. And I encourage you to check these out, especially the manual and the facilitation guide and the PDQ manual, the youth manual. These go in a lot of depth into each of the steps and provide a ton of great exercises for the implementer. So all of these are on the CORE website. I just put this up here so that you could see exactly how to find them. I actually struggled a little bit, so you can see that you go to our technical work on CORE, and then to initiatives, and then down to diffusion of innovations in order to find the entire list. And you know what, I'll turn over to Mary just for a moment, because I know that a lot of resources are available on the FSN top site as well. Mary, are you there?
I think so. Can you hear me?
Yes, we can hear you
great. Yeah, I just wanted to mention that these are also, as I said earlier, the Partnership Defined Quality Facilitation Guide is a FSN Network recommended tool, and these are also available on the FSN Network website's resource library, and I put in a link in the box for that. Yeah, and Cindy's asking if we have a TOT planned for PDQ. We do not. I would love to have names of consultants who are available to lead that sort of thing, though, if people would email me, and I'll put my email address in the box here, too, because it's something we could consider for the future. Thanks.
Great. Thank you very much, Mary, for adding that information about the Resource Center. At this point, I'm going to, we have about 7 minutes left, so I'd like to open it up to any questions for Shahana, Marcy, Ronnie, or Beth to answer. So go ahead and type any questions you might have into the box. Cindy, yours was answered. Any others?
Yeah. I want to mention one point. One is it's very critical to involve the policymakers and the managers who actually manages the health programs in the overall process of PDQ. Otherwise, when we actually run this process at the field level, if they don't get the endorsement from the top level, it's not going to work.
Okay, great. Thanks for pointing that out, Shahana.
Sorry, Dr. Shahana, could you give an example of this, of how it was critical in PDQ for Youth?
Because when we started working on the PDQ in our program when with Save the Children, then we actually had many people who actually deciding so many things from the top level, because we are working at the district level. So if we have some, before starting this one at the community level, simultaneously we have to start this kind of discussion on conversation with the people who are actually working in maternal child health or adolescent health or family planning department at the central level, so that they can provide their endorsement at that point. As because we are thinking of mainstreaming this kind of thing at the services.
Okay, thank you, Shahana. There's another question that just came in from Dr. Salazar. It's about finding a neutral facilitator. So I'm just wondering if any of our resource people or Beth want to comment on how difficult it might be, especially in a small rural community. Is it difficult to find someone that's truly neutral?
I'll speak up initially on that, and that may be if PDQ may have moved beyond this at this point, but in the experience I have, the facilitators that we have used are project facilitators. They're not community members. And so because getting through the Bridging the Gap workshop, it can be really important, I think, to have somebody from outside, because nobody from inside will be perceived as neutral. But part of the goal as you move towards a functioning quality improvement team is that once people begin to see each other, providers and community, as allies and as working together, then that neutrality and the skilled facilitation skills become less of an issue. I don't know if others have used inside facilitators for Bridging the Gap.
This is Beth. I would agree with what Marcy's saying. I mean, the times that we've done it, it was a Save the Children person who led it, just so that it avoids any of the feeling like someone's taking sides. I think the tendency in the community is to want to have the medical provider lead it, because they already seem to be someone as an authority and assumed to be a good leader. But I feel like that needs to be resisted, and finding someone who is a good listener but who's not involved or engaged is really, really critical. So often a project person at least gets the ball rolling so that a quality improvement team is formed. And then, once they are formed, the person that's supervising the quality improvement teams doesn't necessarily need to be that same person.
Okay, great. Thank you, Beth. We only have a couple minutes left, so let's take Julie's question. She's been waiting patiently. Do a lot of the solutions require you to help the community form a building fund or to pool resources to fix something? Any of our resource people or Beth want to comment on that? Go ahead, Ronnie. I see your hand up.
Yeah, I think it's important to tease apart, as part of this process, what are the different options and solutions, because there are times when something really requires a completely technical fix versus other opportunities where, with a little bit of pooled labor or something that's easily accessible from a community, can really make a difference. And so I feel that you really do need to bring in community resources in some way, but it shouldn't be the price of doing this. You know what I mean? There's got to be a balance and a negotiation process to make sure that the solutions being prioritized make sense for what the problem is. So I don't know if that's a direct answer, but it's a consideration when you're trying to think through like what types of problems you might be able to take on.
Hi, this is Beth. I want to just add on to what Ronnie was saying. In Armenia, you know, people contributed clocks from their homes and put them on the wall in the clinic, and carpenters from the community volunteered their services to rebuild the roof. So I agree that that really builds the ownership when people say, yes, we all agree this is a need and we're going to do something about it. But, you know, it can backfire. We tried to do PDQ in one community in Mali, and there was so much NGO saturation that they refused to come to a meeting if the outside NGO did not pay for food and drink. They said, forget it, we're not going to do it if you don't provide this. So that was a difficult scenario.
Okay, thanks Beth and Ronnie for those inputs, and I think that's why I said earlier that it's a tool that not only brings the voice of the community into the process, but shared ownership, and that's what's so unique about PDQ. So Mary asked a question, and I think I will wrap up with this, about other sectors that the PDQ may have been used in. To my knowledge, we've only used it in the health sector and then in 1 or 2 countries in education. But is there anyone out there that knows of it being used in any other sector before we wrap up? Go ahead, Ronnie.
So it's still health, but not public health sector. We had an example of PDQ done in Ethiopia, working with a network of private clinics and private providers working with high-risk populations. There was also a similar piece of work in Georgia with high-risk populations for HIV, so injecting drug users and sex workers and men who have sex with men. And you know, there's 2 things that I wanted to just highlight here as caveats and things that need some more creative approach. In the case of working with the private practitioners, it's a little bit harder because they're not as motivated and don't feel as accountable to the community. However, whoever was talking earlier about the consumerism side of it, you know, there are ways to focus on the things that will most motivate private practitioners. So I think how this is presented to them, you know, as non-public sector is really important, and how the way they're brought into the process and the continual need to help them see the return on the investment of their time and engagement with community is really important. With the key population work in Georgia, they felt that they couldn't completely do the full cycle of PDQ because members of these key populations were practicing behaviors that were illegal, and they were afraid to come forward. There's not enough time to really unpack the learning around that, but the big takeaway for me was that if you do want to try this with marginalized populations, you know, there is an element of caution that needs to be taken when the populations are defined by illegal behaviors and practices. So I guess that's still sort of health, but I wanted to find a way to get this in there.
Right. Great. Terrific. Thank you so much for chiming in, Ronnie. And so it doesn't sound like it has been tried in the food security and or agricultural realm, so that's something we're looking forward to our participants trying out for us. And we're going to wrap up now. We're past the 12:30 point. And I just want to say thank you to Beth, Shahana, Marcy, and Ronnie for being part of this webinar. You guys were fantastic, and we're really lucky to have so much PDQ expertise here with us today. Also, thanks to Mary and Patrick from TOPS for making this webinar possible. And as we mentioned earlier, the recording will be available on the FSN Network website. And I don't know if Mary or Patrick have any final comments.
Well, thank you so much. I'm delighted by the level of participation and the wonderful examples and all the sharing. And thank you, Kira and everyone. I know Patrick will be sending out the recording.
Okay, great. So we'll all get the recording. And with that, I think we'll wrap up. Thanks, everyone, for your participation, and have a good rest of the week.